deflection is seen in flow scalar. So coming to the, now we will go into the pressure and time scalar. I will just briefly explain, and again I will explain you in detail. So pressure scalar, basically it will be like this, whereas the flow scalar will have a positive deflection as well as a negative deflection, whereas the volume time will have only positive deflection. It will be like this. Coming to the loops, pressure and volume loop, sorry, it will be like this, whereas your flow volume loop will be like this. I will explain in detail also, just don't worry, just first get accustomed to these loops. So which is not a scalar in ventilator graphics. Now moving on to the question. So simple, anything that has time in it is a scalar. So basically they're asking which is not a scalar. So search for the option which doesn't has time. So there is no time in the pressure volume. This pressure volume is actually a loop. Okay. So this is the answer. Now simple. Now again the question is which of the following is a flow scalar? So I have told it is easy to remember. Flow scalar will have a negative deflection also. So apart in all these graphs, if you see the only negative thing, so -1, -2, -3, that flow negative thing is seen in case of flow scalar only. So this first one is a pressure time scalar. This one is a volume time scalar. This is basically a loop. So basically it is a volume and a pressure loop. Okay. Now, whenever you are you want to know about ventilation, especially, then you should know three terms, that is T, L, and C. So total leukocyte count, that is how what we call TLC. But in ventilator, TLC means T means trigger, L means limit, C means cycling. I will tell what they are. So what is the trigger? Means which is initiating the breath. The one that is initiating the breath is called as trigger. So who will initiate the breath? It can be the patient can initiate the breath, or if patient is not breathing, ventilator can give the breath. So basically, then you call it as a patient triggered or a ventilator triggered breath. Okay. Next is what is limit? Limit is whenever a patient starts breathing. Let us assume this is a pressure time scalar. So there should be a certain limit or peak after which ventilator should not over distend your lungs. So the factor that is limiting the maximum pressure or whatever it is called the limit. So this is also called as control variable. So the other name for limit is also called as control variable. So there are only two control variables. That is, it can be a pressure controlled ventilation or a volume controlled ventilation. So whenever they say pressure control ventilation, volume control ventilation, you should know which is the limiting variable. It is whether it is the pressure that is limiting or it is the volume that is limiting. Next important thing is cycling. What is cycling? Cycling is the factor which will switch the ventilation from inspiration to expiration. So whenever you want the ventilator to stop inspiration and begin expiration, that is called as cycling. Now we will know what are the triggers, what is the limit, and what are the various cyclings that are available. So coming to the breath cycling in ventilator. So as I have already told, this is the trigger. So A is the trigger. So trigger I have already told, it can be the time trigger, or this is basically the ventilator can give a triggered breath, or a patient can give a triggered breath. So ventilator, how does a ventilator give breath is based on the time. So whenever you fix a particular time below, suppose you tell every breath should be 1 second. So ventilator waits for 1 second. In that 1 second, if patient doesn't breathe, ventilator will initiate breath. So ventilator triggered breaths are basically determined by the time. Okay, so it is also called as time triggered. Other thing is patient triggered. So whenever patient breathes, the ventilator will sense that patient is breathing. How does the ventilator sense whether the patient is breathing or not? I will subsequently tell you. But remember, it is sensed by the ventilator and then the ventilator gives breath. That is called as patient triggered breath. There are different modes of ventilation based on the patient triggered breath. Basically, there are three modes of ventilation that is called as SIMV, that is synchronized intermittent mandatory ventilation. Other thing is PSV or pressure support ventilation. Last is assist control ventilation, ACV. It is also called as SIPPV or PTV. In different ventilators, it has different names. Don't worry about these names. We will discuss in detail later. So basically, you should know it is a trigger is a time trigger or a patient trigger. Time trigger is basically ventilator derived breaths, and a patient trigger basically 3 modes of ventilation we are having. They are SAMV, assist control ventilation, and pressure support ventilation. Next is the control variable. As we have already discussed, there are only 2 control variables. Based on the control variable, the ventilation is named as pressure control ventilation or volume control ventilation. Okay. Now coming to the cycling. Cycling is switch over from inspiration to expiration. So how does a ventilator switches from inspiration to expiration? You can keep it like time cycling. Time cycling means you will give the ventilator, you will set a TI. TI means inspirator time. You will set a time of 0.4 seconds. So after 0.4 seconds, automatically ventilator will stop giving inspiration breath and the expiration will start. So by time, you can decide whether ventilator has to switch over from inspiration to expiration. This is one cycling method. Other is flow. Whenever you are having a flow, this is the flow time scalar. So whenever you can set in a ventilator that whenever a flow is coming to particular level. So this is, you think this is 100% flow. And if the flow is coming till 15%, then ventilator should go into expiration, something like that. This is called as flow cycle ventilation. Or other thing which you can do is a volume cycling. So you ask the ventilator that when the ventilator delivers 10 ml of tidal volume or 10 ml air to the baby, then it should automatically stop giving ventilation. So then once the 10 ml it reaches 10 ml, automatically it stops giving inspiration and exhalation starts. So volume also can determine cycling. So now the question can be asked like, which of the following is not a cycling variable? So it can be, so cycling, basically 3 variables are there. It can be time cycling, flow cycling, and volume cycling. Suppose they give pressure or something like that, that is not the cycle. Okay. Coming to the control variable, there are only 2 control variables: pressure control variable and volume control ventilation. And trigger, I have already told, there are 3 modes of ventilation: patient triggered ventilation, there are SIMV, assist control ventilation, and pressure support ventilation. So apart from this, there is something called as NAVA, neurally adjusted ventilatory assist. This is a new mode of ventilation where you measure the EADI. EADI means electrical activity of the diaphragm. So they will place a special electrode through the NG tube. There is a special type of NG tube to which the electrodes are present. The electrodes will be present at the level of the diaphragm. So whenever patient wants to breathe, so diaphragm muscle contracts. So there will be a electrical activity generated at the level of the diaphragm. So this electrical activity is catched by the ventilator and it will initiate the breath. This is currently the best trigger, because this happens exactly when the patient wants to breathe. But there are some problems with EADA also. So right now we remember there is a special mode of ventilation called neurally adjusted ventilator assist, where the electrical diaphragm activity of the diaphragm, it can act as trigger, it can act as control, it can act as cycling also. So in all these 3, this EADA can be there. So this is a special type of ventilation. So now I have told you that now we will go about one by one, like a trigger, limit, and cycling. Now coming to the trigger. So as I have already told, it can be ventilator trigger or a patient trigger. Ventilator trigger is basically time-based. Patient trigger is, it is whenever patient wants to breathe, then that is sensed by the ventilator by a technology. That technology is called as trigger technology. So how does the ventilator sense? So basically, one thing is, whenever you are connecting the baby to a ventilator, so whenever baby wants to take a breath, so it will take a breath. So there will be some negative pressure generated. So this negative pressure, or whatever the pressure difference which is taken, is detected by a transducer that is present inside the ventilator. That is known as pressure transducer. So this pressure transducer is present inside the ventilator, which is located very far away from the patient, and the sensitivity is very less. This is present in primitive ventilators. This pressure transducer is present. Okay, so this is one trigger technology. Other trigger technology, the latest technology, is the hot wear anemometer. See, this is the diagram of the hot wear anemometer. So basically in the hardware anemometer, you will have a something called a heating element made of some platinum heating element will be there inside. So whenever patient breathes, so whenever air passes, so generally because of some current generated continuously, these what do you call this hardware anemometers are relatively hot, and whenever air passes through them because of the flow by the patient or when he's inspiring or exhaling, they become cold. And to make them hot, some amount of electricity is required. So based on the amount of electricity required, so the ventilator will decide whether what is the amount of the flow, and based on the direction, so which uh, side electrode is getting cooled first, so that based on that it will identify the direction whether patient is inhaling or exhaling. And based on this flow also, the volume is calculated. So this is the latest technology. This is also known as hardware anemometer technology, where this type of flow sensor can detect the tidal volume that you are delivering. So till as of now, the tidal volume measurement, best tidal volume measurement is present only with hardware anemometer. So no other the technology is able to know what is the volume of air taken or volume of air exhaled by the patient. So that is one MCQ. But the problem with this flow sensor is it has to be attached between your ET tube and the ventilator tubings. So there is some dead space because of this flow sensor. That is the only problem with this. So what are the other trigger technologies that can happen is your ECG leads. Sometimes ECG leads, whenever there is a, you attach the ECG leads. So basically whenever patient wants to breathe, there will be a movement generated at the level of the chest. This movement is catched upon by the electrodes and they start the ventilation. But the problem is sometimes there can be hiccups, or there can be chest movements because of some other cause, or these chest slits may come out. At the time, ventilator may not sense that baby is breathing, or it may sense falsely at the time of hiccups or some abnormal movements that baby is breathing and it delivers the breath. That is one problem. Other is something called as Gresby capsule. So this is the diagram of the Gresby capsule. This is pasted over the abdomen. So whenever you try to breathe, there is abdominal movement also. So whenever there is abdominal movement, the ventilator will think that baby wants to breathe and it will deliver a breath. So this is one more thing. So other thing is this last diagram is what we were discussing. This is the EADI. This is nothing but electrical activity of the diaphragm. So the special NG tube is placed in the stomach, and at the level of the diaphragm, the electrodes are present, and this will detect the electrical activity. So what are the MCQs that can be asked from this topic is they will ask which trigger technology will measure the tidal volume generated. So that is with hardware anemometer or pneumotachograph. Okay, so this is the only technology. Second, which technology is the best as of to date is the electrical activity of the diaphragm. Third question, is there which trigger technology will add dead space to your to the ventilation? That is what the question is also. So which technology has additional dead space? It is the hardware anemometer. All other things do not have a dead space. Okay, I think this is clear. Now moving on to the next question. We have completed now about trigger. Now we will go about limit. Limit is, which is the control variable, is called a limit. So control variable is, I have already told, is a pressure control or a volume control. So basically for postgraduate level, if they give the graph like this, so they will ask you in both the graphs which is a pressure control and which is a volume control. So basically you should remember, whenever it is a pressure control, that means the pressure will reach the maximum pressure within a few seconds of inspiration. So at the beginning itself, you will reach the maximum pressure. The pressure, usually the pressure remains constant throughout. In pressure control ventilation, it is also called as constant pressure type of ventilation. So the initial breath itself, in the initial phase of inspiration itself, the pressure is maximum, which is sustained throughout the ventilation, and at the end of inspiration and beginning of expiration only it falls. So similarly, the flow also, the flow will be maximum at the time of inspiration itself, and the volume also rises very fastly. In the beginning of inspiration itself, you will also reach the maximum volume. Whereas in case of volume control ventilation, you may think that volume will be similar because they named it as pressure control ventilation. Pressure is reached maximum at the time of in the beginning of inspiration itself. Whereas in volume control ventilation, you may be thinking volume may be reached in the initial. That is wrong. In pressure control ventilation only, everything will be reached in the within the initial phase of inspiration only. That your flow will be maximum, your pressure will be maximum, your volume will be maximum. But in volume control ventilation, which is constant, is your flow. The volume control ventilation is also called as constant flow ventilation. So the flow will be constant, and at the end of inspiration, you will have the maximum pressure or the maximum volume that is present at the end of the inspiration. So that you have to remember. Okay. So coming to the question, which of the following represents pressure control ventilation? So what I told in pressure control ventilation, everything will become maximum at the beginning of the inspiration itself. So constant flow is no, volume is also no. Yes, your flow is maximum at the beginning of inspiration. Pressure is also at the end of inspiration only, it is maximum now. So the option D is the right answer. Now next question, which of the following does not represent synchronized mode of ventilation? So basically I told there are, I will explain again. Basically I told initially there are two types of ventilation. So that is ventilated triggered or patient triggered. So in ventilated trigger, what will happen? Every ventilator will give the breaths in between. So it doesn't bother whether baby is breathing or not breathing at the time. Suppose let us assume baby wants to exhale at this moment and ventilator is giving inspiration at this moment. So there is a dysynchrony. So there will be inspiration dysynchrony, expiration dysynchrony will be there in case of mandatory breaths. That is called as controlled mandatory ventilation. Whereas in patient triggered ventilation, there are three types of patient triggered ventilation. One is synchronized intermittent mandatory ventilation. Other is assist control ventilation or SIPPV or PTV mode of ventilation. And other is the pressure support ventilation. So how do you know which type of ventilation it is? In synchronized intermittent ventilation, what will happen is, so let us assume whenever patient wants to breathe, then ventilator will give a breath. So whenever patient wants to breathe, so ventilator will give a breath. Apart from that, intermittently, even when patient is not breathing, sometimes ventilator can give breath, and some breaths of the patient may not be supported by the ventilator also. So if you see here, ventilator has supported, here ventilator has supported, here ventilator has not supported, here ventilator has not taken the patient's synchronization. So basically what I want to tell you is, in SIMV, basically what is the advantage when compared to control mandatory ventilation, what is the advantage of synchronization is, so inspiration synchrony will be there, but not all breaths, only few breaths. Suppose baby is breathing at 70 per minute and you have set the SIMV rate at 40 per minute. So only 40 breaths per minute only will be supported by the ventilator. All other breaths are not supported by the ventilator. So all supported breaths usually will have a set PIP, PEEP, everything will be there in SIMV, and they have high maps compared to the normal breaths. Suppose patient is breathing only at 20 per minute, so ventilator will support all the 20 breaths, and additionally it will give other 20 breaths also. So basically it will support only some breaths. So that is present in SIMV. Whereas in assist control ventilation, what will happen is the ventilator will support all breaths of the patient. So if patient is breathing 100 also it will support. If patient is breathing at 20, then also it supports 20 breaths. Okay, so trigger breaths will have a separate color at the end of the inspiration. So all breaths will be supported by the ventilator. Then what will happen in pressure support ventilation? In pressure support ventilation, so all breaths will be supported by the ventilator. But what is the difference between this assist control and pressure support ventilation? So then you should know the difference comes in case of cycling. How I will tell. Suppose let us assume in a ventilator, what are the parameters we set? PIP, PEEP, TI, respiratory rate of the ventilator we will set. So in SIMV, what will happen? In SIMV, you will set the PIP, you will set the PEP, you will set the TI, you will set the respiratory rate. Suppose you set the respiratory rate at 40 breaths will be supported. And if you set your TI as 0.5 seconds, so for this 40 breaths, the TI will be 0.5 seconds. That means the inspiration time will be for 0.4 or 0.5 seconds based on the TI you set. So in case of SIMV, you will set everything. Okay. Whereas in case of assist control ventilation, where you will set PIP, you will set PEEP, you will also set TI. So you will also set whatever the patient will breathe, but you will set that that patient has to breathe, inspire for 0.4 seconds, then patient has to inspire for 0.4 seconds. But important thing, respiratory rate you cannot set because all breaths are supported by the ventilator. Okay, so here you don't set respiratory rate. Now coming to pressure support ventilation. In pressure support ventilation, what will happen? You will set the PIP, you will set the PEP. Important thing is you will not set TI. So TI is determined by the patient. So patient will determine how much time he has to inspire and how much time he has to expire. And respiratory rate also you won't set because that is determined by the patient. So you suppose what is the difference? Now you will understand if you see this graph beautifully. So if you see in this graph, volume, pressure, and flow volume loops, basically these are loops. If you see here, there is in the first diagram there is haphazard. So there is no synchrony between breaths. There is so much of asynchrony happening. Whereas if you come to SIMV, you see that some breaths are, if you see some breaths are having very good synchronization, whereas some breaths are not having synchronization. So partial breaths you are synchronizing, partial breaths you are not synchronizing. Whereas in assist control ventilation, if you see, all breaths are synchronized neatly because ventilator provides support for all breaths. And then how do you, by seeing the graphics, can you tell it is assist control ventilation or a pressure support ventilation? Yes. Basically, you have to see the flow time graph. Example, let us assume. Basically, here you are setting the time. So that is why it is called as time cycle. So SIMV and assist control ventilation, both are time cycle ventilation. Whereas pressure support ventilation is a flow cycle ventilation. I will tell you what it is. So in time cycle ventilation, especially when you have a graph like this, so if you see, there is slight difference between these three graphs. One is here, if you see, patient, the flow has reached maximum and flow has ended, but patient cannot exhale at this moment because the TI is still left. What they said, TI is still left. This is known as inspiratory trap. Okay. So inspiratory lag or otherwise, whenever even after patient completes his inspiration, he has to wait for the expiration because of this inspiratory lag, which is because of the time cycle ventilation. So whenever you see in the flow cycle, there is a gap between inspiration and expiration. So this is called time cycling. Similarly, if you see in the second graph, the inspiration has ended and expiration has started, but still see the flow has reached 0. So it might be a chance that you have put the TI such that the patient TI and the ventilator TI are equal. Only then this happens. Okay. But whereas in flow cycle ventilation, what will happen is the flow will never reach 0. It will stop at a particular limit. Suppose your flow is 100%, you will set like 15% of the flow. When flow has reached down to 15%, then expiration has to start. So here inspiration will happen, and suddenly from here only expiration starts. So basically it is a flow cycle. So for postgraduate level, what you should remember is which of the following are synchronized modes? If they ask SIMV, assist control ventilation, pressure support ventilation, these three are synchronized modes. So what type of synchrony is there? Some inspiratory breaths synchrony is there, then it is SIMV. All inspiratory breaths synchrony is there, then it is assist control ventilation. All inspiratory breath synchrony as well as expiratory synchrony is also there, that is the pressure support ventilation. So inspiratory plus expiratory synchrony, all inspiratory synchrony, some inspiratory synchrony. Okay, that is the difference between SIMV, assist control, and pressure support ventilation. Okay, this is what I have discussed. So now I will go to some theory. So this is very, very important. Please listen to this carefully. So now I will tell you about few scalars. So first I will talk about pressure time scalar. So what can you infer basically by using pressure time scalar? First, you can know what is the type of ventilation. Example, if I show the waveform like this, And if I show the waveform like this, then I will ask you in both of the graphs, which is the pressure control and which is the volume control mode of ventilation. We know in the pressure control ventilation, the pressure reaches the peak in the beginning of the inspiration itself, whereas in the volume control ventilation, it at the end of the inspiration it peaks. So basically, by seeing this graph, you can tell which is the pressure control ventilation and which is the volume control ventilation. Then other thing I will ask is, so whether I'll ask which of the following are triggered with and which of the following are non-triggered with. So whenever you are seeing these things, these are all triggered with. This is not non-triggered with. So you can tell which of the following are triggered with and which of the following is non-triggered with. Third thing which you can tell is rise time. In some ventilator, there is a terminology called rise time. That is the time taken for the pressure to reach the peak. This is called as rise time. So this is called as rise time. So the time taken to reach the maximum. So whenever your rise time is more, that means the ventilator will take so much time to reach the pressure. That means it will be like this. Okay, if your rise time is very low, then ventilator will reach the maximum pressure in a short time. So this is basically called as sine wave type of pattern. This is called as square wave type of pattern. So whenever the rise time is less, you will get a square wave type of pattern. Whenever the rise time is very high, then you will get a sine wave type of pattern. So you can know what is the rise time based on this graph. Fourth thing, what you can determine by using this pressure time graph, that is very, very important for the exam is, suppose if you see the graph like this. So what are the things you will know from this graph? One is the graph is not starting. This is 0, 1, 2, 3, 4, 5, your pressure. This is time. If you see, there is some always a baseline continuous flow going on. The pressure is not reaching 0. This is because you are giving continuous pressure, that is called as PEEP, positive end expiratory pressure. So the one that is present below this is called as PEEP. Then what is the PIP? What is the maximum pressure that is generated? Is called PIP. So in this pressure time graph, you will know this is the PIP. You can see this is the PIP here. So basically PIP minus PEEP is your delta P. Next, what are the other things you can infer from this graph is, see here, you will know what is the inspiration and what is the expiration. So this is the inspiration and this is the expiration. So this is inspiration and this is expiration. So usually inspiration is to expiration ratio is usually 1:2. So if suppose someone asks, what is the area under this curve represent? So what is the area under this curve? So what does this represent? This represents nothing but a mean airway pressure, or it is also called as MAP or mean airway pressure. So why this MAP is important? Because it will determine your oxygenation. So whenever you want to improve oxygenation to a patient on ventilator, what you can do is, first thing is, important thing is, in the graph, what you can increase the PEEP is the first thing. Why? Because PEEP is present both in inspiration and expiration. When you increase the, I will draw it neatly again. So basically, whenever I am increasing the PEEP level, so both in inspiration and expiration, the area is increasing. So by increasing the PEEP, you can increase the MAP. Second is by increasing the PIP, you can increase the MAP, because that is the area under the graph. Otherwise, if you increase the inspiratory time, so then the time in which the PIP is present, then also you can increase the area under the graph. So these are the three important things: increase the PEEP, increase the PIP, increase the TA. Fourth is increasing the respiratory rate without decreasing the TA. So whenever you are increasing the respiratory rate without changing in a TA, basically your expiration will get shortened. But on the whole, because the number of breaths are more, the area under the graph will be more. So increasing the respiratory rate without changing inspiratory time, then also your MAP will increase. So these are the four things by which you can increase the MAP. And on top of that, if you can increase FiO2 also, then also oxygenation will improve. So oxygenation is dependent basically on MAP and your FiO2. So these are the four things by which your MAP can increase. And other thing is FiO2, which can increase your oxygenation. So I hope this pressure, time scalar, all important things have covered. Now we will move on to flow time. Okay, so basically flow time, what you will know which type of ventilation. How we will know? Basically I will ask you, so of this both, which is a volume control ventilation and which is a pressure control ventilation. I told you volume control ventilation will have a constant flow, whereas a pressure control ventilation will have a peak. A flow will rise at the beginning of the inspiration itself. And other thing, based in this graph, if I ask, you can know cycling also. Now I will ask, which is a time cycle and which is a flow cycle. So see, there is a time lag, there is an inspiratory lag is there, and the flow is touching the baseline. So this is a time cycle. Whereas in a flow cycle, even before it is ending, your cycling has started. That is, inspiration to expiration has begun. So this is a flow cycling. So the second thing that you can know from this graph. So other parameters which you can know is, this is known as the peak expiratory flow rate. Okay, so why that is important, I will tell you. Suppose this is the most favorite topic for the examiner, this loop, flow time loop. I will ask, so I will draw 3 graphs and you should tell me what is the diagnosis. Okay, this is one graph. Second graph, third. So basically there are 3 graphs. So examiners favorite graphs, these 3 are. So in the first graph, if you see, basically you are having the rate, your rate is very high, and if you see, even before your expiration is ending, your inspiration is starting. Okay, so this is something called as air trapping. Okay, this will especially happen and air trapping will lead to auto beep generation. Will happen when patients are breathing at a very high rate on a ventilator. Okay, so if you see the second, the expiration is continuing into inspiration also. So this is called as air leak. Yes, excellent, someone has answered, Dr. Guru, as right. And the third one, if you see, the peak expiratory flow has decreased and your TE has increased. That is, expiration time has prolonged and your peak expiratory flow rate has been decreased. This happens especially when there is a bronchospasm. Example, like your asthma or something like that, or a bronchospasm happens, then your peak expiratory flow rate will decrease and your expiratory time will increase. So I think you don't have any doubt. Once again, you see, air trapping means usually the rate will be more and your inspiration begins before the end of expiration. Whereas in air leak, expiration will continue even into the inspiration. Whereas in bronchospasm, your peak expiratory flow rate will decrease and your expiratory time is prolonged. So that will happen in bronchospasm. Okay, so this I think not more than this they can ask. So this is regarding flow time. Now we will move on to the volume time graph. What are the inferences you can get? So I will give you 2 graphs. You have to tell me which is a pressure control ventilation and which is a volume control ventilation. So basically in this 2, if you see, nearly at the beginning of inspiration itself, you are reaching the maximum volume. So this is a pressure control ventilation. Whereas at the end of inspiration, your maximum volume is reaching. That is called the volume control ventilation. So that is common. Other thing is, so your inspiration, it is here and your expiration is not reaching the baseline and it is falling. This is known as shoulder cliffing. So it is like suddenly it falls down. Okay, and again it starts like this, suddenly it falls down, again it will go like this, come down, again it falls down. So basically what this will tell you is, there is some amount of volume which is not coming. Suppose if graph is given simply like this can be air leak or air trap, you cannot tell. But if you follow subsequently, suppose for air leak, what will happen is it will reach to the baseline. Okay, whereas in air trap, it doesn't reach the baseline. It will go like this, keeps on going like this. That is, your baseline keeps on coming up. Whenever your baseline is keep on going up, that means there is some amount of air trapping happens. Whereas your shoulder, this sudden drop or shoulder cliffing is a sign of air leak. Okay, so this is regarding our volume time graph. Now we will go about these loops. This is also a very important topic for the examiners. So basically, I will try to consolidate and I will try to finish as fast as possible. So coming to the VP loop, volume pressure loop, usually it will have like this. This is inspiration and this is expiration. This is inspiration, this is expiration, and this line is called as compliance line. Okay. So what are the things you can derive from this loop? Suppose if I draw one loop, you should tell me what type of ventilation it is. So basically the same graph which I have shown earlier also, this is the controlled mandatory ventilation. This is SIMV mode of ventilation where some breaths are supported and some breaths are not supported. The supported breaths will have more tidal volume and more pressure. And all like all breaths are supported and all are having nearly equal volume is you are seen in what you call PTV or SS control ventilation or SIPPV. So basically what type of ventilation you can tell based on this VP loop. That is one thing. Second important topic, very important for the exam purpose is the compliance. So I will show two graphs. You tell which graph is having more compliance. So can anyone post in the chat box whether the orange one is having more compliance or the green one is having more compliance? Excellent. So Harshini has told it is the green one. How do you know? So compliance means change in volume by change in pressure. Okay. Suppose in the exam you got doubt, okay, which is having a more compliance or not. Simple thing is you fix one thing. Let us assume you fix a volume. So then what will happen? Compliance is inversely proportional to pressure. So how to fix the volume? So this is a volume graph and a pressure graph. So you take a particular volume. So let us assume for a particular volume. So this volume, which is requiring less pressure, is having more compliance. For example, green is requiring this much pressure and orange is requiring this much pressure. So of the both, the more pressure is required by orange and less pressure is required by green. So inverse, no? So the less pressure, the more compliant. So green is more compliant. Similarly, again, I will give you one more graph. So basically A, B, C. So all graphs are having same volume. Now tell which graph is having more compliance of A, B, C. Can anyone put in the chat box? Yes, excellent. A. Okay. So basically when you draw three lines, so now you see compliance is equal to change in volume by change in pressure. So here volume is constant. So now we see which is requiring less pressure, A graph or B graph or C graph. So basically it is the A graph is requiring less pressure. So A is having less, more compliance because it is requiring very less pressure to generate a unit amount of volume. So apart from that, what are the things that we can generate from this volume pressure curve? This is also called as work of breathing. This is how ventilator will detect your work of breathing. So let us assume this is A, B, C, D, and this is E. So just remember, so A, B, C, A means this part will tell you the inspiratory resistance, the work that is done during inspiration, resistive work. Basically, the resistive work that is done during inspiration is ABCA. Other thing is ACDA. So this one, ACDA, it will tell you the resistive work that is done during expiration. Okay. So other thing is this whole thing, ACEA. This entire thing, which includes your respiratory resistive work during expiration also. This whole thing is called as, this ACEA is called as elastic work. That is elastic work that is done during inspiration. So total work is ABCEA. So total work is ABCEA is called as total work. Sorry, something happened. 1 minute. Okay, so it is the total work. Total work is the ABCEA is the total work. So they can ask. So they will give you in the exam in this graph. They will ask you which will represent the. Again, I will ask once again. So now you will have to tell me. I am rubbing this. So I am drawing the graph. So A, B, C, D, and E is the volume pressure. Now tell me which will tell you the inspiratory work during inspiratory resistive work. So can anyone type which will tell you the inspiratory resistive work? ABCA, excellent. So this is the inspiratory resistive work. So expiratory resistive work is ACDA. Now tell me which will tell you the elastic resistance during expiration. So ACA, yes, excellent. So total work of breathing is ABCEA. So okay, now I think more than this I don't think you will need. Only one thing I will tell you. I will draw two graphs. Tell me which graph of this both A and B is having more hysteresis. It is A or B. Question is simple, straightforward. In this both graphs, which is having more hysteresis? Can anyone post? Excellent. It is B. So hysteresis means this thing. So whenever it is bulging like a balloon, it is called as hysteresis. Basically, this hysteresis indicates resistance. If there is inspiratory resistance, the inspirator side will bulge. If there is expiratory resistance, the expirator side will bulge. Okay, inspirator resistance means inspirator side will bulge. Expirator resistance means expirator side will bulge. So basically, so B graph is having more hysteresis. Now at the end, somewhat higher level one question I will ask you that you have to tell me. So what is this called? There is some name to this at the end. Can anyone tell what is that called? Excellent. That is called as beaking. It is like a parrot beak. So what does that indicate? Beaking means you are basically, if you see here to here, so for every unit change in pressure, some volume is getting generated. But at the end here, even there is this much change in pressure, there is no volume generated. That is because this is, you are giving very high PIP to the patient. So patient doesn't need this extra PIP. Patient needs only this much amount of PIPs. For example, you set the PIP of 15, but after 10 you are getting this beak. That implies that already the patient requires only 10 PIP, you need not give additional PIP. So that is called as beaking. That will be given by the ventilator also as a parameter that is known as C20/C. That is compliance in the last 20% to the total compliance. So compliance means change in volume to change in pressure. No? So this is the compliance for this graph, and this is the compliance for this graph. So if compliance is so change in volume to change in pressure by change in volume to change in pressure. Change in volume to change in pressure in the last 20% of the breath. If there is no change in volume for increasing pressure in the last 20 breath, then your C20/C ratio will decrease. So whenever your C20 by C ratio is decreasing, that indicates there is air, what is called, you are giving overinflation of the lung, you are giving very high PEEP, or it indicates beaking. So less T20, C20 by C will indicate beaking, and usually we take it as 0.8. So usually less than 1 itself will indicate that there is inadvertent, you are giving high PIP, but up to 0.8. If it is below 0.8, it means that you will have to decrease your PIP immediately. Okay. Now last loop, that is FV loop. There is a flow volume loop. So easy to remember. Whenever there is flow part, there is a positive wave and a negative wave. Something I forgot in this flow volume loop. Sorry, I'll just 1 minute. I will go through this again. I need some space. I didn't tell about leak. I didn't tell about air trapping and all those things. Okay. So in the VP loop, if the loop has not reached the baseline, so what does this indicate? So what does this graph indicate? Can anyone tell? Can anyone post in the chat box? What does this indicate? Your expiration is not reaching the baseline. Okay, air trap, someone has told. So basically what you should know is, in this volume pressure loop, you cannot tell it is an air leak or air trap. It is very difficult. Both of the times the graph will be like this only. Okay, both, it will indicate both air leak and both the air trap. But how do you know whether it is air trap or air leak? Is if suppose there is a way where the two graphs can be compared. For suppose you see, if one graph is like that, next breath is also having like this, then it is air leak. For suppose this is your this breath, and other breath, second breath, you are having like this, that means you are having additional PEEP. So this is known as air trapping is happening, and which is generating your auto PEEP. So if waves are moving away, then you can tell because of auto PEEP generation, the graph is like that. Otherwise, if I give only this single graph, you cannot tell whether it is air leak or air trap. So this can be confusion. So in volume pressure loop, if it is not reaching a baseline, it can be air leak or air trap. Other thing is, sometimes the graph will have a cusp during inspiration. This cusp is because of your flow starvation. If you are not giving any adequate flow, baby tries to breathe in at the time, so that will create a cusp-like thing. So this air cusping in the inspiratory part of the volume pressure loop will indicate the flow is inadequate. Okay, so this is regarding this thing. Now we will move on to the flow volume loop. Flow volume loop will have both inspiration and expiratory. Now I will show you some graphs. Now you will tell which is a leak, which is a trap. Okay, in the flow volume. So now tell me what is A, what is B, and what is C. So now tell me which is leak. A, B, C, which is leak. Okay, A, air leak. B, what is C then? C, basically there is a decrease in peak expiratory flow rate, and there is a scooping in the expiration. Yes, C is a bronchospasm. Very well done. So basically what you have to know is, whenever in our flow volume loop, the volume, the expirator volume has touched the volume and it is not reaching the level where it is starting, it will tell you it is a air leak. So whenever the volume, what do you call it, is in the expiratory waveform is touching the flow loop, then it will tell you it is a air trap. So here basically what happened is, there is decrease in the peak expiratory flow rate, and this is a scooping is there. It will indicate your bronchospasm, especially asthma-like disorders. Okay, suppose same graph if I am giving like this. So this is, let us assume this is the normal, A is normal. So basically, what is A, what is B, what is C? So in A, what you're saying is both entire loop has become small. Whereas in B, you're saying inspiration is normal, expiration has become small. Whereas in C, you are saying inspiration has become small, but expiration is normal. So can anyone tell what is the A, B, C means? There basically, where is the site of obstruction? Okay, is it intrathoracic obstruction? Is it supraglottic, subglottic type of obstruction or something like that? Can you tell what it is? Okay, basically in the A is what you call it as a fixed obstruction. Example, subglottic stenosis or a very small endotracheal tube they are giving. There will be a complete small, both inspiration and expiration will get decreased. This happens in extrathoracic obstruction, that's right. Whereas in B, your inspiration is normal, but expiration has come, your expiration has come down. Just a minute. Your expiration has come down. This will tell you this is a intrathoracic obstruction. So intrathoracic obstruction means like your asthma and all, that is similar to this graph. Okay. Whereas if your inspiration only is decreasing, but your expiration is normal, it indicates your supraglottic, right? Example, some vocal cord related causes and all can cause this type of graph. This is beyond your level, but simply I have told because of your interest, everyone is responding. So I just kept on adding and increasing the level. Okay, don't worry about this last thing. If you remember these things like air leak, air trap, and this bronchospasm, it is very, very enough to you. Okay, so I think now we will go on to MCQs. We have finished almost everything, and we will now see what is that. So in the graph, this graph has been asked, I think some 10 times or 20 times in the central exams. So basically, can anyone tell basically what is happening in this graph? So here, if you see, I will draw it for you easily. Okay. So at the same time, what happened to flow is, so basically what happened at this point is simple. Basically, if you see in the flow graph here, basically there is an inspirator hole. No? If you see, there is inspirator hole. Suddenly here it has changed to flow cycle ventilation. So till here it is time cycling is happening. Here it suddenly flow cycling is happening. So in time cycling, you have this thing, and if there is a flow cycling, you will have this thing. So many of them have answered that it is changed from time cycling to flow cycling. It is very right, but it is very confusing. But if you see the answer, A, B, C, all are correct. I will tell you why. Suppose, let us assume in this graph, they haven't shown whether it is a synchronization is there or not, something like that. They have not given in this graph. But most of the time, synchronized intermittent mechanical ventilation and assist control ventilation, both of these are time cycle ventilations. So pressure support ventilation is a flow cycle ventilation. So basically, these three options are correct. So it can be there is change from time cycling to flow cycling, change from assist control to pressure support, change from SAMB to PSV. All these three things can happen. So basically, the other thing which you should know is whenever you are changing from time cycle to flow cycle, so what are the changes that is happening? If you see, the map or the mean airway pressure is decreased because the time, your inspiratory time is getting less. So the area under the graph is coming down. So whenever you change from SIMV or assisted control ventilation to pressure support ventilation, what will happen is your mean airway pressures will fall down. And at the same time, the volume generated, so tidal volume is also will fall down. That is why usually once a lung starts improving, you will change from whether assist control mode or SMV2, you will change to pressure support ventilation. In units, isolatedly, we don't use pressure support ventilation. So anyhow, now discussion came. So let us assume this is a SIMV, PTV or assist control ventilation or pressure support ventilation. How do you wean in these three things? Is in SIMV, first thing is you will reduce the rate. Second, you will decrease the PIP. Okay. Whereas in PTV or SS control mode, the respiratory there is complete inspiratory synchrony. So the respiratory rate is decided by the patient. You cannot do anything with the respiratory rate. What you can do is decrease the PIP. That's all. Similarly, in pressure support ventilation also, you can decrease the PIP. That's all. And other than that, you cannot do. Okay. So this is regarding your inspiratory hold. That is not there here. In flow cycling, there is no cycling. So answer will be D. Okay. Any of the above is the possibility. Now I think I will go very fast. Till now what we have completed is just a revision or MCQs. We have finished our class. Now very fast we will go for the MCQs. Which of the following intervention does not increase mean airway pressure? So what are the things that can increase the mean airway pressure? Increase in PEEP, increase in PIP, increase in expiratory time, increase in higher respiratory rate. So answer is C. Okay. Why? Because see in the graph, you can increase PEEP, you can increase the flow. Because if you increase the flow, it will change from sine wave to square waveform. Other thing is you can increase the PIP. Other is increase the TI. Okay. And other is the increase in the rate. But important thing, remember, higher respiratory rate, usually inspirator time is fixed and expirator becomes shortened. So on the whole, the baby in the inspiration times relatively more. That is why you will have a more mean airway pressure. Very good. Now moving on to the next question. Which of the following intervention does not increase ventilation and reduce PaCO2? So whenever, example, you are seeing a blood gas, you have seen a PaCO2 of some 70 mmHg. Okay, you first you thought you have to rule out what? Whenever your PaCO2 is high on a ventilated baby, can anyone answer? Whenever your PaCO2 is more in a ventilated baby, so what are the important things you should rule out? Two important things you should rule out. Can anyone type in the chat box? Come on, fast. So it is nothing but your tube block, tube obstruction. Other thing is pneumothorax. So these two things are very, very important in a ventilated baby whenever you are having a very high PCO2. So once you rule out these two things, like there is no tube block, there is no pneumothorax, then you should try to increase the tidal volume. So the amount of air going into the lungs and coming out of the lungs, you should increase so that the CO2 will be washed out. So what are the ways by which you can increase the ventilation? Is first thing is coming to the answers. If you see, first I will tell the theory, then I will tell you. One thing is increasing in the respiratory rate. So whenever you increase the respiratory rate, more tidal volume will be generated and more ventilation will happen. Second is increasing the PIP. Basically, by increasing the PIP, what you do is a delta P. The difference between the PIP is P you are increasing. So there will be a more delta P or more tidal volume generated because of the delta P. This is the second thing. Third thing is you increase the what do you call as expiratory time. So basically, exhalation of the CO2 happens during expiration. Whenever your expiratory time is low, you will have a CO2 or air trapping and the CO2 buildup happen. So you try to increase your expiratory time. So that is one other thing. So PEEP is something that will have both effects. Okay, how I tell you? Up to a certain limit, like it will have a U type of pattern. Up to a certain limit, whenever your lung is not open, especially RDS like thing, up to certain PWEP, your alveoli will open and there will be CO2 washout, very good CO2 washout. But if you keep on increasing PEEP, what will happen is there will be a distended, alveoli will get distended very like this, and the amount of air moving in and out of the alveoli will decrease, especially when you keep on increasing PEEP. So in the options, if you see, suppose increasing PEEP, PIP, inspiratory time, respiratory rate. So increasing respiratory rate is correct, expiratory time correct, PIP is correct, PEEP is correct partially. But if you go on to theoretically, if you think PEEP, if you are increasing more and more, it will cause CO2 retention. So that is one thing. Okay. Now next graph, very important. So what happened to in the graph A? I have given one medication here, and now this graph B has come. So what does the graph A represents? Can anyone tell? Out of A, B, C, D. So this we have already discussed. That is, whenever your peak expiratory flow rate has decreased and your expiratory time has is prolonged, That will happen because of the bronchospasm. Yes, right. Now, next thing, what does this graph indicate? Can anyone tell? So basically, I will explain. What is happening is your baseline is increasing and your volume is not reaching the baseline. So this we have already discussed, like your baseline is keeping on increasing. Can anyone tell? Yes, this is air trap. Excellent. Now, next question. What does this graph indicate? A similar graph which I have shown prior. So I told no, only one, if only one graph is given, it is very difficult to know whether it is air leak or air trap. Both of them can have this type of graph. Only thing is you should have a second thing, like this is air leak, this is also air leak. But if subsequent one is going like this and like this, then only you can tell it is trap. Suppose I give only this one graph, you may think you don't know whether it's leak or trap. So only one diagram if I'm giving, it can be air leak or air trap. Whereas in previous question I have given the continuous thing, then only you can tell it is air trapping. Otherwise you cannot tell it is air leak or air trap. So both of them will have appear similar. Now tell me, what does this graph indicate? So single thing. Yes, excellent. It will indicate both. I have already told. In a volume pressure graph, if you give only single thing, you cannot tell whether it is air leak or air trap. Suppose the suppose the next one is going like this, and a subsequent one is going like this. That indicates that your auto peep is generating. That is air trapping is happening. Otherwise, if a single wave I will give, you cannot differentiate. Now tell me, what does this graph indicates? Excellent. It is air leak, because I told you, whenever in the expiration is touching the volume, that is leak. Whenever your expiration is touching the flow, that is trap. So okay, I have already told, and this is air trap. Now tell me what is this graph indicates. So in this graph, they are saying there is a decreased peak expiratory flow rate, and this is the scooped out pattern. This is seen in bronchospasm. Yes, right. Very right. Now, this I have discussed previously also. Out of this yellow, green, and red, which is having more compliance? Can anyone tell? Yes, yellow, because for the same volume, the pressure required is less in case of yellow. Okay. So same question in another way. So can you tell which is having, which has more compliance? Yes, again yellow, because I told compliance is equal to change in volume by change in pressure. Basically here we have put the pressure as constant. So if you remove pressure, the compliance is directly proportional to volume. So the more the volume that is generated for a particular pressure, then the lung is told to have more compliance. So the more volume out of the three it is yellow. Okay. Now tell me, what does this graph indicate? Okay, it will indicate over distension. There is some difference between over distension and air trapping. Don't get confused. So basically it is a over distension. So basically you are having a beaking that is represented by your C20 by C. So T20 by C less than 0.8, you should remember. So this question also I have asked multiple times, which indicates elastic work. Yes, ACBA will indicate your elastic work. So in this graph, ADCA will indicate resistive work during expiration. ACBA will indicate resistive work during expiration. ACBA will indicate your elastic work. Total work is ADCBA. Okay. I think we will stop this, and if a problem already time is so much. So only one question I will explain. This is very important for tomorrow's exam, and I will stop the session. This is regarding humidity. So let us assume you have taken a 1 liter of air, and you have seen what is the water vapor present in that air. So the amount of water vapor present in that air is called as, that is milligram per liter. The milligram per liter of water vapor in 1 liter of air is called as absolute humidity. Okay. Now what I will do is, I will take this 1 liter of air and I heat it. So I am heating it. So what will happen? The amount of water vapor that can be taken by the that can be holded by the air increases. So whenever water becomes warm, whenever air becomes warm, so remember, whenever air becomes warm, it will hold more and more water vapor up to a certain point where it cannot hold. Beyond that, it cannot hold water vapor. That point is called as dew point. So what is dew point? Dew point is a point where your air is fully saturated with water vapor, is called as dew point. So from this, what you understood is, whenever you heat the air, it can its capacity to hold the water vapor will increase. So let us assume after heating, let us assume here air is holding 22 milligram per liter. Here 22 milligram per liter water vapor it is holding, and after heating it is increased, it is holding 44 milligram per liter. But now when you measured, it is holding only 22 milligram per liter here. So then they will ask, what is the relative humidity? Relative humidity is a percentage, that what is the water vapor it is present to the what is the capacity to which it should hold. That is relative 50%. So absolute humidity is the water vapor that is present in milligram per liter, whereas relative humidity is the ratio of the humidity that is the water vapor that is present to the water vapor that can be actually holded by the air at the temperature. Okay. So next important thing is, what is isothermal saturation boundary? Let us assume this is the bronchus, trachea, this is your lungs. So normally also whenever we breathe in air, or usually the temperature, room temperature will be around 25 degrees or something, and your room water vapor, it is very less. It is not, there is no very less water vapor in there. And so once we are breathing in air, once it is passing through our nose, turbinates, and it is going down, the two things will happen to the air. One thing is, it is gradually heated to our body temperature. So whatever, even in AC room, if you are breathing in air, by the time it reaches the lungs, it will become 37 degrees centigrade. That is first thing. Second, as the air is getting heated, it will draw moisture from your airways. So from all the respiratory lining, it will take off water vapor, and it will try to become 100% saturated, to have a relative humidity at the time. So the point at which the air which you breathe will reach this 37 degrees with 100% relative humidity. That point is called as isothermal saturation boundary. That is usually present near the bronchus. It is present at the bronchus level. So why this is important? Because suppose you have ventilated a baby and you forgot to on the humidifier. So what will happen? The cold air which is growing inside, usually it is like 4 degrees or 2 degrees. Such cold is the air which is coming from your hospital supply. Air is very, very cold, and it doesn't have humidity at all. It is very dry air. So directly you are giving dry air. So this dry air, while it is going, by the time to reach 37 degrees, it will has to go more deep into the lungs. So the isothermal saturation boundary can go into the lung level. So the more down the isothermal saturation boundary, the more damage to the lung will happen. So that is why it is important. So whenever you ventilate, you will have to give a heated humidified air to the baby. Okay. So I would like to stop the session. If you have any doubts, I think you like the session. So if you have some other time, I think we will discuss in detail, especially in our ADR Plexus course, we keep on discussing these important topics. So if you have any doubts, you can please ask. You can put in the chat box, or else we can just stop the session.